Okay, let's jump straight into it. That moment, your shoulder just gives way, pops out.
Awful feeling.
Instant pain, major disruption. But what's really frustrating, isn't it, is how often it happens again.
That's the real problem, recurrence.
We've been digging into the orthopedic literature, JAS and others, and some numbers are pretty stark.
Well, yeah,
For certain young, active patients, after that first traumatic anterior dislocation, if they don't have surgery, nearly 9 out of 10 might dislocate again.
that statistic really sums it up. It's the core of what we're looking at today. Shoulder instability.
Mostly traumatic anterior instability, right? That's the common one.
That's the most frequent presentation, yes. And it's not just about reducing the dislocation, getting the ball back in the socket.
No.
It's fundamentally about understanding the damage done, often over multiple events, and how that damage makes the shoulder, well, inherently unstable.
Exactly. So this deep dive isn't just about a simple repair. It's about how orthopedic thinking has moved on.
It has, towards much more precise diagnosis and really tailoring the management based on exactly what injuries you find.
So our mission, pulling from these sources, is to get a handle on the current evidence.
Spot on. What are the key factors driving treatment? How do surgeons pinpoint the real underlying problems? And crucially, what does a successful outcome actually look like, especially in stopping those repeat dislocations?
That high recurrence rate, particularly in young, active people, it really stands out. It sounds like the who matters as much as the what.
Oh, absolutely. Patient selection, understanding their specific risk profile, it's crucial for predicting the outcome and hopefully getting a good one.
And what are the big risk factors the literature points to?
Well, there are a few key ones that come up consistently. Younger age is a big one, especially under 20, maybe 25.
Right.
Male sex is another factor. And perhaps, obviously, playing collision sports or just participating in high-level athletics significantly bumps up that risk.
So a young male athlete, they're right in the danger zone for it happening again.
That's the highest risk group, yes. And because non-operative treatment, just rehab after the first time, it has such a high failure rate in these high-risk individuals, especially the younger ones. The trend is definitely towards surgery becoming the mainstay.
Even for the first dislocation sometimes.
Often for the primary instability in that demographic, yes. Not just for recurrences. The thinking is to intervene early, break that cycle before more damage occurs.
Okay, so if surgery is often the answer, that initial diagnosis has got to be spot on. You need to know exactly what broke, not just that it popped out.
Absolutely foundational.
Yeah.
Can't stress that enough. It starts with a really meticulous clinical evaluation.
Taking a proper history.
Detailed history, yes. How did it happen? The mechanism. How many times before? Crucially, how old were they the first time it happened?
Age at first dislocation matters.
Big time. And also, what are their goals? Are they hoping just for pain relief, or are they trying to get back to playing rugby or competitive swimming? Very different demands.
Makes sense. And the physical examination, what are you looking for there?
The exam is key for assessing the degree of instability. How much does the humeral head, the ball, actually move relative to the socket, the glenoid?
How do you test that?
We assess glenohumeral translation and use provocative tests, things like the apprehension and relocation tests, trying to mimic that feeling of instability the patient gets.
See if you can make it feel like it's going to pop out.
Exactly. And then see if relocating the head, sort of pushing it back gently, makes that feeling go away. We also look for general joint laxity.
Like being double jointed elsewhere.
Sort of, though the sources mention general scores like Baton aren't always that helpful specifically for the shoulder. Things like excessive external rotation or a sulcus sign, that little dimple under the shoulder suggesting downward laxity, can be more telling for the shoulder joint itself.
Okay, so history, exam, then you need to look inside, presumably. Imaging.
Imaging is non-negotiable, really. It confirms what you suspect clinically, but more importantly, it identifies the specific structural damage.
Starting with x-rays.
Usually plain radiographs, yes. They're good for gross issues alignment, obvious fractures. And specific views, like the Grashy, axillary, Bernigo, Stryker notch, West Point, they help visualize the bone shapes better.
Looking for those bony defects?
Precisely. But, and this is important, the sources point out standard x-rays often miss more subtle bone loss, especially if it's not a fresh break or a really chronic problem.
Right. So x-rays for the big bony picture. What about the soft bits, the ligaments, the labrum?
That's where MRI comes in, or arthrography MRA. These are essential for evaluating the soft tissues.
The labrum, capsule, ligaments.
Exactly. And importantly, in patients over 40, The rotator cuff tendons as well. They can tear during a dislocation too.
MRA involves injecting dye.
Yes, contrast dye into the joint. It's generally considered more sensitive for picking up more complex or subtle tears, things like panlabral tears going all the way around, or SLAP lesions up top where the biceps attaches.
And standard MRI.
Standard MRI is noted as being particularly good for those anterior labrum tears, the classic Bankart lesion. And checking the rotator cuff in older patients is vital. Finding a tear there can definitely change the surgical plan.
Okay, MRA for soft tissue. What if you suspect significant bone damage that the X-ray didn't really show clearly?
That's when CT scans become crucial, particularly 3D CT reconstructions.
Why 3D?
The sources are very clear on this. The end-phase sagittal view you get from a 3D CT reconstruction is the best way to accurately measure, to quantify, the amount of glenoid bone loss.
And getting that measurement right is critical.
Absolutely vital, because that number, that percentage of bone loss, heavily influences the treatment decision.
And the sources really drive home how important these bony injuries are, don't they? They're not just side effects, they dictate the whole strategy.
They really do. The two main bony problems in recurrent instability are glenoid bone loss, GBL, and Hill-Sachs lesions, HSLs.
GBL is damage to the socket rim.
Yes, wear or a fracture off the front edge of the glenoid socket, the shallow dish the ball sits in.
And the Hill-Sachs is on the ball part.
Correct. It's an indentation, a defect, usually on the back upper part of the humeral head, caused when the ball impacts the sharp glenoid rim during the dislocation.
It's like the ball hitting the edge of a damaged cup, it dents the ball and chips the cup rim further.
That's a good analogy. It's often a cycle of progressive damage. Each dislocation can make both defects worse.
And the sources talk about a newer way of thinking about Hill-Sachs lesions. On track versus off track.
Yes, that's a really important concept now. It seems to be a more reliable way to predict recurrence and surgical outcomes compared to the older idea of just engaging versus non-engaging lesions.
What's the actual difference, on track versus off track?
It's about biomechanics. Think about the glenoid tract, the contact area on the socket. An on-track Hill-Sachs stays within that contact zone during normal shoulder movements. It's there, but it doesn't slide off the edge. An off-track lesion, however, is big enough or positioned so that when the arm moves into an unstable position, like abduction and external rotation, that defect on the humeral head actually translates medial to the front edge of the glenoid. It essentially falls off the track. It loses the bony stability of the socket rim.
So off track means it can basically slip past the point of no return much more easily, leading to another dislocation.
Precisely. Identifying an off-track lesion is critical information. It changes the whole stability equation and really pushes you towards surgery that addresses that humeral head defect too, not just the glenoid side.
And the amount of glenoid bone loss is just as critical. Are there specific percentages that trigger different treatments?
Yes, the literature talks about definite thresholds. There's a bit of variation, but common figures are, say, less than 10% or 13.5% GBL.
Okay, minimal loss.
Then an intermediate zone, maybe 13.5% up to 20% or 25% loss, and then significant loss, greater than 20-25%. Crossing these thresholds usually means you need a different surgical approach to get stable.
It sounds like knowing these numbers, understanding the bone damage, it almost creates a flowchart for treatment.
That's absolutely the direction things are going, an algorithmic approach. The type and amount of bony damage, the GBL percentage, the on-track, off-track HSL, combined with patient factors like age and activity level, that dictates the best strategy.
So arthroscopic surgery isn't always the answer.
Arthroscopic stabilization is often the first thought, and it works well for many, but the sources are clear. It's not one size fits all, especially not when you've got significant bone loss or other high-risk factors.
Right. So let's walk through the surgical options then. Starting arthroscopically, what's the standard go-to?
The foundational arthroscopic procedure is the Bankart repair, using keyhole surgery, scope, and small instruments to reattach the torn anterior labrum back to the bone of the glenoid rim.
Using little anchors.
Using suture anchors, yes. The aim is to restore that bumper effect of the labrum and tighten up the capsule a bit.
And when is that the recommended route?
Primarily for patients with minimal or no significant glenoid bone loss, generally cited as, 0-10% GBL. Some even suggest considering it for young, high-risk athletes with less than 5% loss, just because their recurrence risk without surgery is so high.
How well does a standard Bankart work on its own?
Well, the results vary quite a bit in the literature. Recurrence rates reported anywhere from, say, 6% up to over 35%.
That's quite a range.
It is. But here's the crucial bit, tying back to bone loss. Studies show a dramatically higher recurrence rate, some up to 67%, if you do a standard Bankart repair in someone who does have significant bony defects.
Like that inverted pear glenoid shape from bone loss or an engaging Hill-Sachs.
Exactly. Compare that to patients with no bone loss beforehand, where recurrence after a Bankart can be as low as 4%.
Wow. That difference is massive. It totally underlines why you need that precise imaging first.
Absolutely. And the risk factors for a Bankart repair failing echo the general recurrence risks, but add surgical points. Younger age, male, more prior dislocations, high-level sport, using fewer anchors, more glenoid bone loss, and having a significant HSL or an ALPSA lesion.
What's an ALPSA lesion again?
It's where the torn labrum heals, but it heals in the wrong place, peeled off and shifted medially. Doesn't function as a bumper anymore.
Okay. So if there is some bone loss, say in that intermediate 10-20% zone, or a tricky Hill-Sachs, but maybe not bad enough for open surgery, can you boost the arthroscopic approach?
Yes, definitely. The literature talks about arthroscopic plus procedures for these sorts of situations. Two common ones are combining the Bankart repair with a remplissage or doing a double-row capsulabral repair.
Remplissage. Interesting name. What does that involve?
Remplissage means filling in French. It's a technique used for those engaging or critically off-track Hill-Sachs lesions, usually when the glenoid bone loss isn't too severe, maybe under 25%.
And the goal is to stop that Hill-Sachs catching.
Exactly. You arthroscopically stitch the posterior capsule, and often part of the infraspinatus tendon from the rotator cuff, right into that Hill-Sachs defect on the back of the humeral head.
So you're literally filling the dent.
Pretty much, yes. Filling it with soft tissue to stop it dropping off the glenoid edge when the arm's in that vulnerable position.
Does it work?
Studies show good results in preventing recurrence in the right patients. The main potential drawback mentioned is that tethering the tendon there can sometimes limit external rotation slightly. Might be an issue for throwing athletes, for example.
Okay. And the double-row capsulabral repair?
That's suggested for moderate glenoid bone loss, maybe 10-20%, when the soft tissues are still good quality and there isn't a major Hill-Sachs issue.
How's it different from a standard Bankart?
Instead of just one row of anchors on the glenoid rim, you use two rows, one on the rim, and another set further medially on the neck of the glenoid.
What's the idea behind that?
The idea is to create a much broader, more robust footprint for reattaching the labrum and capsule, trying to build a stronger buttress, essentially. The sources mention it, but also note there's still limited comparative data. More research needed to really prove its long-term value against other options for that level of bone loss.
Right. So arthroscopic options cover minimal loss or can be augmented for moderate loss or specific HSLs. What happens when the glenoid bone loss is really significant, over that 20-25% mark?
When you cross that threshold, or sometimes with specific off-track HSLs where other methods won't cut it, the literature generally points towards open surgery. Arthroscopic fixes alone often aren't enough to restore stability then.
And what are the main open procedures discussed?
Well, one is specifically for when there's a displaced glenoid fracture fragment that represents significant bone loss, say over 20%. That's glenoid open reduction and internal fixation, or IF.
Fixing the broken teeth back on.
Exactly. Open up, put the bone fragment back where it belongs, and fix it with screws or maybe a small plate.
How does that fare?
The evidence base is a bit smaller compared to other procedures. One study showed no redislocations if you get good fixation in the right fracture types. But it also noted some patients had hardware issues or maybe didn't get full function back. It's really reserved for those acute displaced fractures where fixing the original bone makes most sense.
Okay. And the other big open procedure, the one often mentioned for significant bone loss, the Latarjet.
Ah, yes, the Latarjet, definitely a key procedure when glenoid bone loss is substantial over that 20-25% mark, usually, or for certain off-track Hill-Sachs lesions where other options aren't suitable. It's really designed for significant bony deficiency.
Remind us what the Latarjet actually does.
It involves taking a piece of bone called the coracoid process. It's part of the shoulder blade, along with its attached tendons.
The biceps and coracobrachialis.
That's right, the conjoined tendon. And transferring that whole unit, the bone block and tendons, to the front of the glenoid socket, fixing the bone block there with screws.
And that creates stability how?
It gives you what's called a triple blocking effect. First, the bone block itself extends the glenoid surface, acting as a physical buttress.
Stops the ball sliding forward.
Yes. Second, the transferred conjoined tendon acts like a dynamic sling, tightening up when the arm goes into abduction and external rotation, that unstable position.
Right, a check-ring effect.
And third, you usually repair the capsule over the transfer as well, adding more stability. So it's bone, dynamic tendon sling, and capsule repair.
A combined approach.
Very much so. And the sources report good success rates in terms of restoring stability, preventing recurrence, often 0% to maybe 9% recurrence in those difficult cases with significant bone loss. It's very effective for stability when the bone structure is compromised.
So why isn't it the first choice for everyone with bone loss, given how stable it makes things?
Well, it's a bigger operation. It's open surgery, more involved than arthroscopy. And it does carry a higher risk of complications.
Like what?
Things like nerve injury, there are important nerves nearby infection, or problems with the bone graft healing or the screws. Reported complication rates can be up to 25% in some series.
So it's a trade-off, stability versus risk.
Exactly. That higher risk profile is why it's generally reserved for cases where the indication is really strong, that significant bone loss, or maybe a failed previous surgery, or an off-track HSL that can't be managed arthroscopically. It's usually not the first-line treatment for all instability.
Are there other ways to add bone to the glenoid apart from Letarjet?
Yes, the sources mention free bone block procedures.
Yeah.
Using bone graft, either from the patient themselves, often the iliac crest, the hip bone,
Autograft.
or using donor bone, allograft, and fixing that to the anterior glenoid. These are sometimes suggested as potentially having a lower nerve risk than Letarjet theoretically, and they're also good options if a previous Letarjet or other bone block has failed.
We focused a lot on traumatic anterior instability. What about other types, like being unstable in multiple directions, or dealing with kids whose bones are still growing?
Good point. The sources do touch on these. Multidirectional instability, MDI, is a different beast altogether.
How so?
It's usually instability in two or more directions, front, back, or down. Often linked more to general ligament looseness, being naturally hypermobile rather than one big traumatic tear.
So the cause is different?
Often, yes. And distinguishing MDI from traumatic unidirectional instability is vital because the treatment starts differently.
How do you manage MDI initially?
Almost always starts with non-operative treatment, a really intensive, focused physiotherapy program, strengthening the rotator cuff, the muscles around the shoulder blade to improve dynamic control.
And surgery?
Surgery, usually tightening the capsule arthroscopically, a vascular plication or shift, is really only for cases where a prolonged, dedicated rehab program hasn't worked. And even then, the literature suggests surgical outcomes for MDI can be less predictable, maybe not quite as good as for traumatic instability.
And what about the youngsters? Skeletally immature patients with open growth plates. That must be tricky.
It absolutely adds complexity. You've got to protect those growth plates, the physis. Prompt reduction of the dislocation and some immobilization is standard first aid.
But what about surgery?
Well, for athletic teenagers, say 14 or older, who have a traumatic dislocation and a clear Bankart tear is found, the sources suggest early surgery might be warranted.
Even though they're still growing?
Yes, because their risk of recurrence without it is just so high. For younger children, it's less clear-cut after a first dislocation. But if they start having recurrent instability, surgery is generally considered, though the techniques have to be adapted very carefully to avoid injuring the growth plate.
Okay, so pulling all this together then, if you had to summarize the main message from this deep dive into how we manage shoulder instability now.
I think the core message is that the whole field has evolved. It's way beyond just fix the labrum. While arthroscopic repair is still common, the absolute game changer, the critical factor driving strategy and outcome, is identifying and accurately measuring the bony damage.
Specifically the glenoid bone loss and the Hill-Sachs lesion.
Exactly. Especially quantifying that GBL and understanding if the Hill-Sachs is on track or off track. That information is paramount.
And that bony picture dictates the treatment algorithm.
Precisely. The amount of GBL primarily tells you whether a simple arthroscopic repair is likely enough, or if you need an arthroscopic pluses procedure like remplissage, or if you really need to go to an open reconstruction like a Letarjet or free bone block to restore proper bony stability.
It's incredible, really, how understanding the bone in such detail changes everything for what seems like a common injury.
It really underscores the complexity, doesn't it? And, the sources remind us it's still evolving. We need more research to validate some techniques like the double row repair, and always looking for ways to improve outcomes and reduce complications for the bigger procedures like Letarjet.
It makes you think, doesn't it? Considering how much this precise lesion-specific understanding of bone changes the game for shoulder instability, how could applying that kind of detailed algorithmic thinking based on the specific damage help us tackle other complex problems? Maybe not just in medicine, but in other fields too.